And give it a couple more minutes so we can have some more people join us, and then we'll go ahead and get started today. Hey, I'm going to go ahead and kick us off. Hello, everyone, and welcome to this installment of the Kno2 Partner Engage webinar series, where we bring you industry news, thought leadership, education, and examples of the impact of interoperability. Before we get started, I'd like to review a few housekeeping items. We will be recording this session, and I'll share the recording and the slides with all of you after this call. Please make sure to use the chat feature for any comments, as all the webinar attendees will be muted, and please don't forget to use the Q&A feature. I'm going to go ahead and quickly introduce our panelists today. So we have Dr. Peter Shuck, our Chief Health Officer here at Kno2, Teresa Bell, our co-founder and president, and finally Matt Becker, our VP of Interoperability. Thank you guys for joining us. I'm looking forward to the discussion today. So without further ado, I will hand it off to Teresa Bell to get started.
Well, good morning or afternoon, everyone. And for those that joined us the last time, I guess I'll apologize for having to see us again, but welcome back. For those that haven't, this is looking forward to another exciting discussion today. I keep calling them our exciting first because over the last year and some, we've had many exciting firsts. And here we sit again today with another exciting first. And it's the ability for individuals to be able to access their information on demand and pull their own clinical information. And it's a major breakthrough for our healthcare ecosystem. So very excited to be able to talk about it. But before we start, I thought we'd spend just a quick second reflecting on the phrase individual access services versus patient access services. And you'll notice that it's not called patient access because it really highlights the intent and the spirit of what we're trying to accomplish by giving individuals or consumers, which Dr. Shuck has educated me that we are really referring to in healthcare, individuals and patients as consumers. And it's really to reflect the spirit and the intent of individual access services. And that's truly to give everybody control over their health information, whether I may be an active patient or not at any given time. Think about our financial lives. Imagine today, I was thinking about this today, is that if you either go to apply for a house loan or you're looking to get a credit card or some sort of loan, and you have to get access to your financial information. So you may have multiple bank accounts, you could have a credit card, you may have a 401k, and you have to go access this information to be able to apply for this event. Imagine if you went to your bank or your banks and you showed up at the bank and said, hey, could I get access to my financial information? I really need kind of the last 2 years worth. And they said, great, fill out this form. And in 7 to 10 days, it'll be ready for you. Would you like us to mail it to you? And then you go to your credit card and you have to fax over a request for records. And they say, okay, yep, we'll send this back to you in 3 to 4 business days. We'll have it faxed back to you. And that's the way you aggregated your financial information to attempt to apply for a loan. Of course, that's not our world today. That's completely preposterous, but that absolutely represents much of what healthcare feels like today for patients. Now, of course, we've seen some access where today you can get access to certain parts of your record, or certain providers have their clinical information available online through patient portals. But even accessing your information through patient portals, one, you have to manage multiple logins. Two, you may have to manage what parts of your records getting access. So go back to that financial example. If I logged into my bank today and I had access to my checking account, but I didn't have access to my savings account, I couldn't see that. That's similar to what we can see with patient records. As we've seen historically, they may get access to parts of their patient record, but not the complete record. Or I may not have access to it at all through certain providers that may not be online. And that's really the opportunity that's sitting in front of us as a healthcare industry, where on demand, a patient through a single application, that they've directed and they've been identity proof for can get access to their clinical information now and bring it back for different purposes that they intend it to be used for. But that is really the excitement of today's discussion and today's webinar is ability to get through this and what we've accomplished as an industry, because we all know it's been a long time coming. And the folks on this call, my fellow panelists, have a long-standing passion and have been working hard to see this come to life today. So super excited about the discussion. We're going to break this down into 3 points. First of all, we're going to go through a little bit of history on what's happened and the milestones that it's taken us to get here today, and then get into kind of the meat of what IAS actually stands for. What does it mean to have individual access services and reaching far beyond a PHR, even though that is a great opportunity for patients to access their information? And then what are the known challenges that we have left to accomplish as an industry to work through with individual access services, because we are just getting started. So as we jump into this, we're going to handle this format a little bit different than we did the last time, where after each slide, we're going to open it up for discussion among the panelists. So as we work through these slides, I have encouraged our panelists not to talk as much. So it's a little bit hard for those that listen to our podcast. Sometimes it's difficult to get a word in edgewise with these two, but I promise you we're going to push through these slides and we're going to have a great discussion, exciting, and let's get started. So Maddie, if you don't mind moving to the next slide. So as I mentioned, it feels like it's a little bit surreal, right? So sitting in 2025, when I always say we have self-driving cars, we have artificial intelligence changing day over day, month over month, and here we're still sitting talking about why can't I access my clinical information as a patient, right? The dichotomy is fascinating in 2025, but there's many, many reasons for it. And it's been a big mountain to overcome to be able to sit where we sit today. And that's going to be part of our discussion. But we wanted to walk a little bit through history. So as you see here, it's not like it's been a topic that hasn't been discussed. It's been discussed for 2 decades. And there's been multiple milestones along the way that have enabled the opportunity that we have today to be able to discuss it. So for instance, HIPAA, obviously, that is a fundamental change in healthcare that was required for patients, because what HIPAA did, besides all of the aspects to privacy and security, of course, is that it gave a legal and enforceable right for individuals to access their health information. Because prior to 1996, prior to HIPAA, it was up to the state. There was no single legal enforceable way that a patient could say, I want access to my health information. It was up to the state, sometimes up to the individual provider. And so then it was kind of just a mess on the national level. And that's what HIPAA looked to govern and bring some standardization to that. Then we move on to high tech, move a few years forward, started in 2009. Even though this was primarily a technology focused legislation, it was primarily focused to the technology that providers use. That was foundational to bringing that clinical information that was sitting largely in paper charts to that point, because we only had teen percentage level adoption in physicians and health systems of EHRs at that point. And in other parts of the market, it was in single digits, if in some cases completely paper-based. And without the requirements that we had to move into electronic health records, which also then started to organize how health information was collected, we would, of course, never be able to access that clinical information online. Going back to that financial example, it's like your bank keeping all of your information on paper on a ledger, right? So they had to get to basic foundation operational components to allow then that information to start being collected consistently. And then also with meaningful use, and there's lots of opinions on the value of meaningful use, that we're not here to debate that. We'll have that as a different podcast. But the value of meaningful use is that it incentivized the sharing to a degree. It incentivized the sharing of information between providers with patients and with things like state health information exchanges, which then patients could go access their records. So again, not perfection by any stretch of the imagination, but started to build the foundation towards individuals being able to access their information. Then we fast forward the clock to the Cures Act, of course, and really Cures was a major stimulus forward, not only for things like the TEFCA framework and for other initiatives, but really the patient was at the center of the Cures Act, right? So we talk about patient-centered FHIR-based APIs, Cures certified EHR technologies. And underneath that, again, is another technological shift forward now with the patient at the heart of it, saying, hey, all the data that you guys are collecting, we need to do that in a standardized format. We need to make it available through actually Fire-based APIs that the patient can access, and start to build this, again, continue to build this foundation that we had for patients to be able to access their information. The piece that was missing with the Cures Act and with everything that happened before is I couldn't do it at scale, right? So if I was a patient, especially a complex patient, and I was going to go from one provider to the next and I had multiple providers, or maybe I'm managing records for my child, I couldn't do that at scale. I had to go log into the portals, manage my individual logins, and if I was ever seen across the country or I moved, there's lots of challenges that were introduced with this. But again, it was that necessary foundation to move forward to then what we've accomplished in TEFCA. So we bring forward TEFCA. Obviously, our very first focus with TEFCA was around treatment and getting the definition of treatment under TEFCA defined. And then quickly moving into pushing forward on individual access, which was really kind of a anticipated aspect of TEFCA before TEFCA actually even started operating. That TEFCA was to be used for patients to access their clinical information. And here we sit today, and that's absolutely come true, that TEFCA has done that. But and go ahead, Matt, if you want to move on to the next slide. So as part of TEFCA, now that we have an acting SOP, or a standard operating procedure for individual access services, it becomes really important to understand, what does that actually mean? And what does that mean for setting kind of that system free? So in looking at this, this is where I'm going to open it up to my lovely panelists that I have joining me today. Let's go through, Matt, I'm going to pick on you first. Tell us a little bit about the definition. What is individual access services, and when did it become a reality in TEFCA?
So individual access services has been one of those long debated things that had to be defined pretty succinctly in order for folks to get started with it. And so one of the things with individual access, the definition really is that an individual human validates who they are and has access to their medical record through anybody that's joined TEFCA. And it is one of the required elements that health systems share data with those entities that are providing that data back to the patient. In that case, it's usually an application in between that facilitates both the technical requirements and the operational requirements for how an individual gets access to their record. And there are specific pieces that we'll go over in this presentation, but really that the actual definition not only defines how the individual gets access to their data, but the protocols to which the individual actually proves who they are, that Matt Becker is the one actually requesting his own record and making sure that all happens through that transaction.
Great. And why did it come to life in TEFCA? What was it about TEFCA that actually drove it? Because we have other national networks and so forth. It wasn't addressed there, right? Why TEFCA? Why now?
So it was tried on the other national frameworks, and it just didn't hold water, and it just didn't gain steam because of the fact that there wasn't this public-private partnership that TEFCA actually provides. So having HHS, having the Office of the National Coordinator for Health IT, all these folks involved, given the fact that from a legislative perspective, individuals' access to their own data from 1996 to HIPAA through the 21st Century Cures Act to now has been a major priority that individuals get access to their data. They were able to leverage that and push that into the public partner partnership that is TEFCA, where the private kind of networks failed to prioritize it in a way that got to the meet individual rules that needed to happen to ensure the trust that actually getting access to their own data. There was a lot of barriers to entry in order to get that actually moving. Solved is this push to make sure that it was a priority, figured all those things out, and actually got it live.
Great. And I don't know if it's on my side, but I think we're having a little bit of connectivity issues with Mr. Becker. So unless that's on my side, hopefully not. But real quickly, so I'm going to then now bring Dr. Schuck into this conversation.
Yeah, let me just a comment on this regard. I think it's funny, and I don't know if it is a common misconception or perception in technology that we've solve for individual access. Let's be honest, back in 1920, when you were seeing a physician, you had access to your records, and the physician was the steward of records, and it was all your data, and you asked the physician for the information. The physician passed it on to whomever they needed to pass it on with your permission in order to care for you in that way, right? Whether it was under consent of treatment or individual perception. What we've done through this technology is actually, and as healthcare became more and more complex, more providers were involved, society became more mobile, we saw people from different entities, and all of our care wasn't rendered by a single GP in the town where we lived. It became harder and harder and greater burden on the individual to get access to their individual records. And then when that all that data became digitized, there were new fears that HIPAA addressed. But we've always had access to our data. It's just become more and more difficult to get that data, and because of the fragmentation in healthcare, the technology involved, and to your point early on, the differences in how states and individuals providers dealt with that. So from a policy perspective, it was made easier with HIPAA. From a technical perspective, it's been made easier with individual access. The thing that excites me is, again, I see the patient in the middle of all this, and I think people can get tired of seeing patient-centric stuff, but the reality here is this is an opportunity, not a burden. Yes, there's a responsibility with having access to your records, but what this has done is unlock it and make it easy and put the power. I love the financial example that you gave earlier. It puts the power of getting and managing your clinical information in the palm of your hand, just like your financial data. And I couldn't think of something more important even than financial data is your personal health information. And again, there's a number of different uses that we talk about, personal health record and so forth, that we'll get into. But I like it just because it puts the power back in the individual's hands to be the curator, an assistant curator of their own record in a way that they choose to do so.
I think that really leads into the heart of the slide that we see here on the screen. And we could go on, we were debating on how many circles here to have on the screen, because really accessing your clinical information can come from so many different sources, and they're continuing to grow. But being able to do that through a centralized way is individual access services. As Matt touched on, what's different about IAS than, let's say, treatment, of course, is who's requesting the records, being the patient, or I just caught myself, the individual asking for their information, but they've been appropriately identity proofed, right? They have to go through a very stringent identity proofing to make sure that they are who they say they are. And then there's a very specific workflow that has to happen as they access that clinical information. What I'd love to do is kind of walk through some different use cases, because of course, what I think conjures up in most people's mind is they say, hey, a patient having access to their records, they immediately think of maybe an app on their phone, a personal health record on my phone, where I go and collect everything. And for those that have listened to podcasts and have listened to me speak, I've been one of the biggest naysayers saying, we think that patients accessing their clinical information is going to be this game changer in the health of this country, right? And historically, I've said, no way. Right, accessing your clinical information, yes, important. The patient deserves that capability, but it's not necessarily something that's going to trend our health differently in this country. Now I'm actually backing away from that statement because of all of the technology, and we've heard it said internally that really what individual access services does is provide technology providers the opportunity to actually change healthcare. And also, you take something like artificial intelligence. So if I have an app on my phone and I go pull the information from the broader community, and now I have, instead of me trying to read through these records and figure things out and figure out the notes, figure out the lab results, which I would never be able to do that, nor would the average American be able to do that. We sit with an AI empowered app. Now they have the ability to start to understand their records, but just as important, how to take action and what to do to start to take action on their records. So I want to open that up for parts of the discussion, but also make sure that we touch on other applications of IAS that may not be thought about outside of the personal health record, but it really opens up the entire landscape in healthcare that sits out kind of outside of treatment and payment and the rest of the landscape for individual access. So I'm going to open that up for either one of you. If anybody wants to opine on that for individual access.
I do have something I want to just, I do want to start and delve into the personal health record a little differently, because I too, like you, believe there's probably about 5% of Americans that actually want to curate their own health record and will take their entire health record from provider to make sure that the care they receive is exactly what they think they need in that regard. And that is people with chronic diseases, complex chronic diseases, rare diseases, people caring for loved ones with difficult diseases or disabilities. And there is a portion of the population that will definitely benefit from that. But now think about that with, you mentioned AI and a couple other things. Now think about a potential virtual provider, right? Or virtual assistant to help you with your electronic health record. So now you've got all your own clinical data, and now you have somebody who can an app or a bot that can process that information, answer questions for you related to that information, pull pieces of that information and trend it so that you can actually have a much more understandable picture of your health. And with AI, you can make it a third grade level, fifth grade level, 10th grade level, 12th grade level. And remember, healthcare literacy in this country is at about a seventh grade level. So it's an incredibly important, powerful potential tool to overlay on a personal health record. Now, additionally, that's bidirectional. It's not only interpretable of the data that you have there in that personal health record, but now imagine personalized, customized fitness and health recommendations, lifestyle recommendations that don't come from an app based on 2 or 3 questions you put in, but come from an app that you may answer 2 or 3 questions, but then it also pulls from your actual clinical data and your health data. So it knows what level of weight bearing you need post a surgical knee replacement or whatever. And it actually tailors that to your piece. And then it reads back the information you get in the improvement and continues to iterate on that. So personal health record takes on a completely different environment when you couple it with individual access, AI, and the lifestyle management that you would want to do. And I want to say one thing, I'll let Matt comment on some of these as we get into some of these other pieces. But this individual consumer is an incredibly important pivot in terms of how we talk about patients. And there may be clinicians out there that still hold on to the patient framework. The reason we change that intentionally is you have very little agency as a patient historically. You go to a doctor, you request an appointment, you get an appointment on their schedule or their time fee. You have no idea what it costs you. You can't comparison shop effectively because there has not been historic transparency in pricing, et cetera. You don't have a good understanding of true quality outcomes or consumer experience before you go. And quite frankly, decisions are made for you and on your behalf largely, and not necessarily you leading those decisions. Versus a consumer who walks into an electronics store and wants to buy a high definition TV. There is price transparency everywhere. There are there are Google reviews everywhere or other reviews everywhere that allow you to understand every feature of the TV, what's good and bad, what other consumers liked and didn't like. As I mentioned, you comparison cost. You can go in, you can touch it, and you are the one making the final decision. And the person who's selling it to you is only making recommendations. A huge different thing, the empowerment of being an individual consumer with individual access services versus being a patient where it's very, very difficult to get your records. It is historic in that regard, and I think that's why we're changing. Now we'll get into the use cases in addition to personal health record that can illustrate that point.
Yeah, I think from my perspective, when you have complex conditions, these 15 to 30-minute hops from provider to provider, from specialist back to your PCP, where they're not really with you afterwards, leads a lot of gaps. So when we're talking about things like what you're doing after that visit and after those doctors' recommendations to really affect your own healthcare, that cause and effect gets lost. So we talked about in the industry things like medication adherence and refill reminders and making sure folks are fill rates and things like that are the terms and the catchphrases that you all know. But what really matters to patients is this idea of like trending and like cause and effect of your life choices on your own pieces of healthcare. And that just doesn't happen when you're seeing your PCP for a physical once a year or you're going to a different specialist, et cetera. And Dr. Shook's points, the idea of individual access is to put that power in your hands and how you actually share and use that data in your own day-to-day life to more bridge the gap with that cause and effect, to make sure that the choices you're making that can make a real effect on your own healthcare and your own life, and then bringing that back to your next specialist appointment, to your next PCP, to not only show your progress and how you did, but be able to show that cause and effect to be able to make recommendations on your life kind of going forward in that 15 to 30 minutes, so that you can kind of make incremental progress rather than going back, explaining everything over again, explaining the things that you did. You have it all right there.
You know, it's interesting too, Matt, that you talk about that, because I do think it also empowers patients to be a much more focused, informed advocate for themselves. And unfortunately, in a complex healthcare system, it is very important that you maintain your own advocacy. So when things aren't feeling right, when you can't get an answer to your questions, that you actually have the information that can help lead to better advocacy and getting those answers. Teresa, I know you want to get into some of these other use cases, and I want to talk about one just to see the conversation, if I can, from the perspective of, just imagine that you are somebody who's been diagnosed with a rare disease. And there aren't, you've tried all the known cures, you've even tried some off-label uses of drugs based on what your providers said, or you have, or there's no treatment for that disease. This empowers an individual to coalesce, to request their medical records, get a comprehensive picture of their medical records, and if they wanted to, could send it to a research institution to say, do I qualify for a research study in this rare disease, right? Something that is not permissible under the auspices of the treatment definition, and shouldn't be under the treatment definition from a screening for a research trial. But this patient can determine, hey, I want to send it out to these providers so that I can get screened to see if there's a research trial that might be something I haven't tried before. That's an empowerment for a patient through individual access that doesn't currently exist today in the national exchange frameworks.
And the final thing I'll say is that we just don't go ahead. We
No,
don't know.
go ahead.
We
I
don't
queued
know.
everybody up for this, so go ahead.
we don't know all the use cases yet. By putting the power in the consumer's hands, what we're actually doing is unlocking innovation in healthcare. And we're really unlocking the ability for the second tertiary data sources to be able to take those records on the patient's consent and making sure that the patient is taken care of in the best way possible. And we just don't know all the answers yet, but we know the problem that we're solving.
Yeah, and that, Matt, I love the innovation piece there. And the best determinant, and Trace is trying to get a word in edgewise. She talked about Matt, she talked
moderator job ever.
She talked a lot at the beginning that we're letting people into a family podcast, I think is what we're doing. But I love the idea of the innovation, but I also think too, it's allowing the consumer to determine the value of sharing their records, right? And with whom they share their records. There's a responsibility in that, and there's some education that needs to occur because once they share their records, they're out there and secondary to use, all that kind of stuff. But it really puts that power squarely on the in the auspices of the individual consumer.
I think it's I'm just gonna pause there in case somebody else. Just kidding. I think what's important in all of that is many of the use cases that sat outside of treatment, outside of things that we're going through right now, so some of the sub purposes of use for operations and payment, they were never going to, I shouldn't say ever, but it was unlikely that they would be resolved in my lifetime, which that's growing shorter and shorter, but like it was unlikely because there's so many challenges with it as relates to privacy, and it relates to some of these challenges. So take like research, what you're saying, Dr. Shuck, trying to solve for HIPAA purpose of use of research in our previous ways of doing work, where somebody would like say, yes, I consent, and they'd hand off their consent to that research team, and then that research team could call the health information management department and get their records over. Two weeks later they show up. That's an entirely different world than when we have a federated infrastructure where people can query for information on demand, including research companies, things like that. And there's a lot of consideration and challenge that's set around those. And so that's, to Matt's point, putting that back in the hands of the patient, it solves a lot of those use cases that were likely never going to be solved or have a real long path before they get solved in the TEFCA framework. And it puts it into the hands of the patient to say, I'm going to choose. where my information goes, right? I'm going to choose what I'm okay with releasing. And of course, there's education, and we'll get into that in the next slide, that needs to happen with that. But it really does set the healthcare industry free for all the challenges and headwinds that we're facing as a healthcare industry. Much of it can be solved and wrapped up here with individual access services as we see innovation. Imagine the innovation that will come around this and the technology that will come around being able to do this. So super excited for that. And as the moderator, I'm paying attention to time, but as we, and Dr. Shuck, I can tell in your,
Yeah,
I'll
no,
go
no, I do. I just on that, to put a finer point on that as well. Nobody, I say this all the time in healthcare, who wants to call their primary care physician and ask permission of somebody who just graduated high school, my front office staff, to come see me sometime between the hours of 9 and 12 or 1 and 4 when it's convenient for me? Nobody wants to do that. That's not the way anything else in our life is done. We still do it in healthcare, and it's crazy. This does not require anybody's permission for you to use your information in a way that you think benefits you in that regard. And really, it's open in terms of the creation of the app, whether you're advocating for yourself around prior authorization and those kind of things, whether you're advocating for yourself for research trial or whatever it is, which is unique, whether you're using it to improve your own health and your own care plans. So I know we're getting short on time, so let's keep moving. T.
Well, I'm gonna actually go back to highlight something that Matt said here that I think is important, because we have an internal debate. It's a debate we've had ongoing as it relates to that second bubble, is send my information to my providers. And I have a personal example of this everybody's heard me talk about it probably at this point, with my dad. He recently, less than 30 days ago, was hospitalized again, and for some unknown reason, the hospital could not retrieve his records from his neurologist and other care providers that he was participating with. And so they wanted to get access to the clinical information as quickly as possible. So I had to work through a website it was this kind of generic website of requesting records. And it literally took me through 17 screens to request the records, to come to the end to say, for an urgent request, by the way, I checked that box. I made sure I checked that box. For at the end to say, hey, we'll get this to you in 3 or 4 days, meeting our urgency requirements. We'll get this to you, and you, or do you want it to send to another provider? And if you have anybody else you want to send us, go back through the whole process again. If you have the next person you want to send it to, because I wanted to send it to the hospital and to my dad's neurologist, which basically behaves as his PCP. I wanted to send it to both. And it took me 34 screens to get through the access to that information to distribute it. And in that case, the debate we've had internally is that that's really still a treatment problem, right? The providers should be able to access information on demand anywhere and be able to pull that information. And that is a problem we continue to tackle as a separate work of effort. But what Matt highlighted is the ability to progress those visits as a patient, right? So it's not only about facilitating the movement of my information, which is between providers, that's a treatment problem, and that needs to be solved as a treatment problem. But now for a patient to access it in between and do something with it, action on it, make it better, follow through, and then provide that and be able to measure the outcome, that's power. And that's not something that has been done historically, because you leave your doctor's appointment, who remembers it, right? I don't, that's like, wah, wah, wah. You don't remember all that stuff that they tell you to do. You take the medication. Sorry, Dr. Shuck. But it's really an exciting opportunity. So I wanted to highlight that. And then maybe we could just touch on, although we've kind of circled around this one a little bit, but the opportunity to share this with third-party apps. So we talked about research as one of those examples. What other examples can you guys bring to mind? So if I, as a patient, I pulled my records back and I access them, and now what we know through some of the partners that have actually integrated to our IAS services that we're bringing live, they have the ability to choose who they want to distribute all or parts of their record to as approved downstream. That's critical because the patient has to approve it. Downstream receivers of their information. Give me some examples of other types of applications that you could see here.
I think they're as broad as your imagination, to be honest with you. I mean,
which is pretty narrow.
Well, maybe yours, mine's pretty broad. But I think when I think about how many wellness apps or how many apps are coming across the app stores on a daily basis or a weekly basis that are being developed to offer some semblance of health and wellness to individuals. Imagine how they could be empowered with individual clinical information to make much more personal recommendations again, on a wellness journey, a fitness journey, or a health journey in that process. And I separate those out only because they're stages of disease or non-disease and recovery. But so I think there's one opportunity there. I think about things like life insurance, good and bad components of that. I think about things of workers' comp or legal implications and so forth, and the timeliness of being able to get those records and advocate. I think of things where you're actually sharing with a payer information that's very hard for them to get because you're advocating for yourself for coverage of a medication or a procedure for an uncommon disease state. I actually think I love what you guys said about how you point out what Matt was saying about progressing care and not just the sharing of records at the point of care, because I think that's the lowest common use of individual access. It shouldn't be something that a patient has to carry their record to the doctor. We'll solve for the doctor having your record. This is about what you can do with your information above and beyond what that is. And then I think about the bidirectional, the idea of reciprocity here, which is the thing we'll get into in the barriers. But imagine being able to share curated information back to your provider around your fitness schedule, your blood pressures, your home monitors, your glucose, those kind of things, which can be done in a standard way through IAS in some cases. I know there are barriers to that. Matt knows those technical barriers a lot better than I do, but we're getting there. It opens up the possibilities to think through that and what's valuable there. So
I think it also puts us ahead of the curve in terms of what future use cases are going to look like, or even present use cases that really haven't been adjudicated. So things like behavioral mental health are big ones, and the fact that, like, if I want to share my record everywhere, it's still not going to be shared everywhere because of certain aspects of my health record aren't going to move with me because of 42 CFR Part 2 and some other laws that are in effect. And really just like even next level treatment, like food banks. If I'm doing things with a social worker, things like that are really going to help drive my own mental and personal health outside of the traditional four walls of the healthcare system. Putting that in the power of my own hands allows me to take that when those the pipes for connectivity between those may or may not exist. And so, like, I can guarantee it exists 100% of the time because I have my phone.
Matt, I love what you mentioned though about behavioral health, because do we anticipate, will we be advocating for differences in release of that restricted information to an individual verified versus a healthcare provider, right? Because there are some limitations in how that's shared now that may not have to be limited if I'm sharing it back to the individual because they were present in that counseling visit, right? So their counseling notes are something that's known to them and might be beneficial as they choose to share it with a different provider, different person, et cetera.
Yeah, and consent management's hard. But the idea of you requesting your own record and just basically consenting to that in the moment, that is a guarantee of consent of, no, I consent to you sharing the record with myself too. And so you can skip behind all the barriers we've been working on for years and years in terms of consent management in order to get that record yourself.
So it sounds like you guys are painting a fantastic world. So, man, everything must be perfect with IAS. Is that accurate? We're good to go. It's 100% perfect.
No.
Okay. All right. Let's get into that. Great discussion, and hopefully we'll get some good feedback from that. Maddie, let's go ahead and move on to the next slide. So, as mentioned, individual access has been in the works, all the foundation, everything that's been put in place, a lot of thought, a lot of consideration, a lot of complexity. So when I give the example of the financial institutions, a little bit tongue in cheek, because it doesn't represent nearly the same complexity that we see in U.S. healthcare. And I say it just to represent what the world should be like, but we have a lot of considerations and still a lot to come. So we're just getting started. The industry is just getting started now with federated individual access, meaning now we have it in place, we have a technical framework in place, but we really want to touch on some of the challenges that we know are sitting there as part of key challenges to overcome. So, Mr. Becker, I'm gonna pick on you first here. You're welcome. Talk to us about some of the obviously there's a tremendous amount of privacy and security risk. We could be here for another 3 hours if we touched on that. Give us some highlights on things that are being discussed around that.
So from a high level to just a lower level, high level on security and privacy risks. Number one, just acknowledging that there's going to be a limitation. The fact that some of these protocols we're using to actually verify that you are who you say you are only applies to you. And so things like proxy access and power of attorney and all these other things are things we need to iterate on in IAS. I think the other privacy and security risk is really trusting the application that it sits in the middle of you having access to your personal health records. And so I don't read the terms and service of Apple when I get a new iOS system. I just click agree. Are patients going to do that when it comes to these health records and things like that? And so one of the things that on a TEFCA policy side, we've done a lot of work on is set the rules for how privacy and security actually work in a TEFCA world that add on to the basic things that the FTC has said that apps need to do. So holding them to the standards of HIPAA is a new piece of policy technology essentially that we've had in the TEFCA world. In addition to this idea that folks have to very clearly state their privacy rules in terms of building these apps and things like that. So we've iterated on these processes in the future. Nothing can really take the place of good judgment either. And so really making sure the health systems are typically concerned about making sure that those are transparent and making sure that folks understand what they're downloading and sharing when they do. But at the same time, a lot of those have been worked through in TEFCA policy, and it's up to the patient to make sure that they're actually taking a role in not only ensuring that they're getting their health records and what they're doing with it, but also the privacy and safety of that as well.
Great. And Dr. Shuck, I don't know if you want to add anything there. Otherwise, I'm going to move on out of interest of time here.
Yeah, not on that. I was going to move on to complete record set and write back a patient data and those kind of conversations, because I do think one of the challenges is that, and this Matt knows this well from his previous life around the Open Notes project in the early 2000s or 20 teens. We speak two different languages. Providers and patients speak two different languages. The purpose of the medical record was to speak to myself over time around a patient in a language that I understood, which is all the training that we go through, med school, residency, fellowships, etc. And it was to speak to other professionals in the field who spoke the same language. So many times there are things that can be difficult to interpret, which is why I think AI is so valuable here. And when I talk about the healthcare literacy in this country being about the 7th grade level, that's a generous estimation. There have been some studies that indicate it's lower than that. And that's not to be demeaning at all, but it's to your point of wah, when the doctor talks. There's very little of what we say that's truly understood and ingested in the context of a 15 to 30 minute visit, especially with all the fear, anxiety, and everything else that's going on. This provides the whole record for them to digest, but it's not in a language they clearly understand. And quite frankly, there may be things recorded that weren't translated in the same way to a patient. And one of the big ones is always morbid obesity versus lose a little weight, right? Your provider tells you to lose a little weight and you're going to get a record set back that says morbid obesity. And it has to do with because the BMI is above a certain level, and we didn't think it was necessary to pile on and say you're morbidly obese, but just to say lose a little weight, here's the diet, here's the exercise plan. So I think there's going to be some interpretation there. And then the other piece is around reciprocity, right back patient data. I think there is value in patient-reported data, how we distill that value, how that gets presented, how that gets ingested in the EHR so that it doesn't become noise for the provider and misinform the provider, will be incredibly important to understand as we go through it. But I think there's value there from a clinical perspective.
Before you open that one, I was gonna cut you off there, but the complete record set, let's go back to that, because I think there's multiple aspects in which we can look at that. So one, taking it from kind of a holistic perspective, if I go see a provider, what part of my encounter or part of that, particular episode, depending on how it's termed based upon the care setting, do I have access to? And then what part of my entire record with that provider do I have access to? And then I go across the ecosystem. I get asked all the time is, so if I go through individual access services, am I going to be able to access my entire record across healthcare? No, that's not today, because that's the problem we're solving. So in parallel, keep in mind, we're solving the treatment problem where we have significant portions still of the healthcare ecosystem and providers, for multiple reasons, including they were never incentivized to be on the national networks, and they're getting on the national networks. They're bringing it forward. They're normalizing their data. And then we have aspects that are they're certified technology. They've been out there for a long time, right? And we're quickly looking to solve that problem. But during the meantime, you're going to get access to the providers that are online today, that are making their individual information available online through TEFCA, to make sure that that's clear today. Hoping to solve that problem over the next, it's going to get better day by day, week by week, month by month, as more and more providers come online. But today you do not have access to your complete patient record set if you've been across the continuum. Now, if you've seen a PCP, you've been to the hospital once, you've had a light, kind of a light history, you probably do. But depending on the complexity of the patient, your age, there's a lot of factors here. Those record sets are coming online over time. So those are some challenges, again, that's actively being solved. Go ahead, Dr. Shuck.
No, I was just going to say, I think there's a lot more records available today, however, that make IAS real today for patients.
Absolutely.
There are certain parts of the healthcare ecosystem that we serve and are actively getting online that I think will broaden that out. But I think, and quite frankly, for people who have complex clinical histories, probably more of their record is online right now, or available online right now, because that meant you were served at a hospital or an inpatient facility for some period of time. So I think it's a really good point. You will get the records from the people who are connected, and our job is connecting everybody. And I think that we're making progress in that on a regular basis.
Right. So then, Matt, I want to touch on just a little bit, getting to the SOP for individual access here. For reciprocity, let's combine reciprocity and write back of patient-generated data. What's the requirement in the SOP, and what are some of the exceptions that may sit around it?
Yeah, so in general, the idea behind TEFCA is one of reciprocity, is that if you're getting data, you're going to share data back. That's the incentive for everybody to play by the same rules. That's the incentive for everybody to join the framework. That doesn't stop with treatment. That applies to individual access as well. And making sure that those records are available upon patient consent back to the broader TEFCA community, which includes hospitals, skilled nursing facilities, et cetera. And so the idea behind reciprocity as it currently stands is that the applications have to have the ability to send back data to the broader TEFCA ecosphere. It is going to be up, because this is outside of HIPAA, this is not an automatic transaction. It's going to be up for the individual patient to say, yes, I authorize my records to go back. But at the same time, the technology needs to be there for the patients to opt in and say, okay, I want my individual medication adherence records, whatever you're collecting on me, to be able to send back. It's not this, we're going to gather your record and then just send the records back to the people who sent them to you in the first place. It really is that new data that you provide as a patient that we want to make available upon consent back to those healthcare institutions.
And so, really important distinction. And then I'm gonna turn this clinical for a second and ask some questions around that, Dr. Shuck. Really important distinction and difference between treatment and individual access, right? So both are built upon the same TEFCA infrastructure. The difference being is you can query for patients' records. You can query for, a provider can query for patients' records to another provider setting. In the case of a provider to provider, under the purpose of use of treatment, it is a required response with a complete data set, right? Required response back for care coordination. They have to give it back to that provider. In the case of individual access, if you are generating new stuff, I'm just going to repeat what Matt said, is if you're generating new clinical content, it is a required response by the technical framework, but only if the patient's consented to send it back, because it's not covered under HIPAA. So it's different. And that's an important piece as you're looking for the technologists in the audience. And we really do try to represent all the audiences that we have on the phone from a technical perspective, things really to consider as part of that, and what to consider. Dr. Shuck, I think you were going to say something though, so I'll pause before I ask you a question on the clinical side.
Go ahead and ask the question, Teresa. Go ahead.
I was going to just say, if you look at all the places that we create patient data today, we probably should call it consumer data, by the way, just to continue to perfect our language, but consumer data. So Fitbits, my fitness trackers, my Garmin, what's on my phone. There's many different areas, and including some engagement back in applications for progressing, as we talked about before, progressing of my conditions forward. what's valuable to you? When does it become all too much? And what's valuable to you as a provider? And I know that's a really broad question, but just give me kind of a general sense to that.
Yeah, I'll give you a general answer because I think it's true whether you're getting information for treatment and delivering, receiving information from treatment across a network, or you're delivering information back from an individual app of consumer reported data. I think the reality of it is context specific, and time, quantity, and trending specific. So in other words, I don't need 2,000 blood pressures over the last month from a app where you're taking your blood pressure every day. I don't need your heartbeat every hour, every day as you go through it for the vast majority of things. What I need, and I think it allows, from a perspective of Matt's comments earlier, it allows innovation on the app side to build, hey, I know for X diagnoses, these are the valuable things that clinicians want to see. I can bundle your information that you're capturing in this way and send them your trended hemoglobins, fasting, and 2-hour postprandial to understand how your diabetic therapy is actually going, even before you get your A1C. I can send blood pressures morning, after exercise, whatever it is. I can send your heart rate from these samples, post-exercise, pre-exercise, so that it's actually getting context-specific information that's relatable to a diagnosis. And to me, it's no different, Tracy, than the conversations we've had about treatment, where I say, don't give me more data as a provider. What I need is information. I need that information in the context of an individual patient with their diagnosis, their medical history, in front of me in my workflow so that I can make appropriately timed decisions. I don't think it's any different with the information that we put back from an app, which gives application developers a responsibility, but also a real opportunity to differentiate themselves in terms of how they go to market with individual access applications to be able to provide the opportunity for patients to report back, or consumers to report back their own data. And I think that's a really neat opportunity, quite frankly, and a really neat area of innovation that will drive significant clinical value.
I would agree. And I think that, just out of interest of time, I'm going to kind of summarize it here, in that the value and the veracity of the data, both to the patient, right, and from the patient back into the larger healthcare ecosystem. A lot of thought, a lot of opportunity, and thank goodness AI is here because it would have been a really, really tough challenge. And it has been a really, really tough challenge for us to overcome on getting as Dr. Shuck always says, getting the right data for the right patient into the right workflow at the right time. And that's not an easy equation, right, to solve, but we have a lot of technology now that's making it much easier to solve and push forward with. So Dr. Shuck, maybe I'll have you, looks like you're going to say something, and maybe you can wrap it up with patient and consumer education, and then we'll open it up for questions.
That's a really hard thing. I was going to actually, because we were at time, I was going to actually go to the question that James Bateman asked in the chat, because I thought it was an interesting question. It probably requires some opinion from Matt and yourself as well. So his question really is super interesting. What if the app, something like MyFitnessPal, that does meal logging, are they going to report the meals back to the network or my clinician? Well, right now that's not part of a standard record set that would go back, but you could see value in being able to report the content of your meal, the caloric content of your meal, back to a provider who is providing treatment for diabetes or for weight loss or those kinds of things. And again, given what Matt said about how this individual access is designed and differs from treatment, the individual consumer would choose if that was the information they wanted to share back or not. Right now, I don't think there's a way to get that back in a discrete fashion, so it would probably come back if it came back in some sort of a PDF or unstructured fashion. But I could see a potential use for that. So the patient and consumer education, just to close that, because you asked me to say something about that, I think Matt touched on it with the ongoing privacy and security risks. And Peter Parker's dad said it the best: with great power comes great responsibility, and we're certainly empowering individuals with access to their clinical record, but there is a responsibility that comes with that. And I, like Matt, I don't think I've ever read a term of service on any app I've ever downloaded. I'm sure my data is everywhere because of that. And when they click share your data to make it better, I usually do that too. So the question is, how do we educate consumers that now they've got their clinical records sitting on their phone? They probably ought to do things like password protect their phone a little bit better. All those simple little things actually read the terms of service, clearly understand what information is able to be shared back, understand how you click it, how you control those privacy settings in that regard as well. So I think there's a fair amount of education that needs to occur alongside of this. Some of it is incumbent upon us in the interoperability industry, some of it on the network, and a lot of it on the application providers that are actually accessing that data and providing those terms of service to the individuals. But I'd love for you guys, if you have anything different that you'd want to say.
I think it's really going to be up to the application folks to really figure out what format makes sense for your data. I think the MyFitnessPal example is a really good one. No, you're not going to want to provide back a huge PDF of every meal I've had since 2007. What you're going to want to provide is if correlating what my actual doctor's prescription is in terms of what my dietary restrictions are, what my dietary plan should be, and comparing that to the app. So if they want me to stay away from simple carbs, maybe that's the count we provide to the provider. If it's a count caloric day by day over under a certain number, that's what we provide. And then there's going to be some innovation and some real thought that needs to go into that before you just jam pack a bunch of information back to a provider.
Yeah, and
we need to make sure that we're providing the right data back.
And that's on both sides, right? I mean, the application needs to figure out the format that is most meaningful, but then it can still come unstructured because right now there's no mechanism to receive, grams of carbohydrates per meal or total caloric intake into an EHR. So how do you do that effectively as well? I will tell you that I'm still comfortable looking at unstructured data and incorporating it into my decision making if I'm not filtering through thousands of documents in order to do so. So. Yeah, it's really interesting. And imagine that you just could share back an AI narrative of the last month of your fitness journey. AI is looking at all the data in your app, and it's giving Mr. McMahon is a 50-year-old guy that has diabetes, et cetera. Over the last month, he's been very good adhering to his diet. He's been on schedule with his medications. His blood sugar has averaged X, Y, and Z. And you're giving a check-in to your provider on a regular basis. Imagine how that might decrease the need to see the provider and the inconvenience of seeing. I mean, just so anyway. All right, I know we're at time, Teresa. You got to cut me.
There's so many things I wanted to say right there. You know how refrained I've been. Other than now I'm hungry, given then I'm going to go set my glucose monitor off and take a nap. So, all right. This has been a fantastic discussion. Look for more of these. As I had said, there's a lot of activity happening on the interoperability stage, the national stage. We're having a ton of fun. It's also a lot of hard work. Clearly, there's a lot left to overcome. But look forward to the next discussion, and then I'll hand this back to Maddie for any final housekeeping items.
Yeah, thanks, Teresa. Great discussion, guys, and everybody on the call. If you enjoyed what you heard today, if you scan the QR code here, we recently released a podcast with Teresa, Dr. Shuck, and Matt Becker, where they dove a little bit deeper into IAS. And Jeff just dropped a link in the chat for you guys to go listen to that podcast. And we'd love to hear your feedback on that, what you liked, what you didn't like, and things that you'd like to hear in the future. So appreciate you all joining today. I'll email out the recording, the slides, and then keep you in the loop for our future webinars. Have a great day.
Thank you, everyone.